Hello, my name is MRIincardiomyopathyKADIYALA. I'm tuning in from Tufts Medical Center in Boston. Thank you to the organizers for inviting me to this wonderful conference. I wish I was there in person in Bratislava along the beautiful Danube. Today, I will present a brief review of cardiac MRI and cardiomyopathy, focusing on the recent update. I have no relevant disclosures. The question is if I have a good echocardiogram with information on ventricular size, function, and valve function in a patient with cardiomyopathy, when and why would I need a cardiac MRI? Heart failure can be a result of many conditions: ischemic, non ischemic cardiomyopathy, valvular heart disease, and a host of other conditions. But specifically, the term cardiomyopathy refers to a myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, valvular disease, or congenital heart disease. So, tissue is the issue here. Cardiac MRI excels at characterizing tissue using various CMR-based sequences such as T1, T2, which can reliably identify fat and edema. Using gadolinium-based contrast agents and delayed imaging techniques, presence of fibrosis, scar tissue, and inflammation can be identified. CMR can also be used to identify increased capillary permeability based on early gadolinium enhancement images. A major strength of cardiac MRI is its ability to do accurate and reproducible volumes and ejection fractions. Due to its high spatial resolution and reproducible acquisitions, modern post-processing algorithms can accurately trace endocardial border with minimal human input. The short-axis slices are used to calculate volumes in end diastole and end systole, and a summation of disks method is used to compute volumes and ejection fraction. Serial changes in volume and function can be reliably tracked with cardiac MRI. The recently published European Society of Cardiology guidelines in 2023 is a pioneering document that moves and shifts our thinking of cardiomyopathy from an etiological classification to a phenotype-based classification. Is the chamber dilated or is it non-dilated? Is it restricted? Are the walls thick? These are the phenotypes that are heavily emphasized in the diagnostic and management approaches of cardiomyopathy. Much of cardiac MRI-based diagnosis relies on pattern recognition of late gadolinium enhancement. The patterns may be described as subepicardial, subendocardial, patchy, or linear midmyocardial, RV insertion point fibrosis, transmural, or a combination pattern. These are illustrated in these examples. Let us look at some case examples. In this elderly patients with progressively worsening heart failure, the cine images show an increased septal wall thickness and mildly reduced LV ejection fraction of 42%. On T1 mapping, the native T1 is markedly increased in a global pattern. The T1 mapping is a pre-contrast sequence that can provide important tissue characteristics, as we will see in the next slides. T1 mapping may also be referred to as relaxometry or mapping. On late gadolinium images, there is diffuse enhancement of both LV and RV myocardium, as well as the atria. In addition to the increased native T1, the calculated extracellular volume was markedly elevated at 57%. These are classical findings of cardiomyopathy. A reminder about extracellular volume. Unlike native T1 maps, which are a pre-contrast sequences, ECV calculation requires pre- and post-contrast T1 acquisition. In this example, both native T1 and ECV are markedly elevated. ECV, or extracellular volume, is an important metric that is now obtained routinely and reliably on modern cardiac MRI technology. In the past, it was nearly impossible to estimate diffuse fibrosis, which is a key disease process. Think of lung or liver fibrosis. The heart is no different. As you can see, the middle graph, ECV is increased in most cardiomyopathy, including HCM, dilated cardiomyopathy, etc. However, in cardiac amyloidosis or infarcted tissue, there is marked expansion of interstitial space and the ECV is markedly elevated. ECV is also been shown to correlate with survival, with increasing ECV associated with increased cardiovascular events. In 2024, we have more tissue characterization tools. It is not just patterns of LGE. We can use T1 maps to help us determine the underlying process. For example, a reduced T1 is seen only in three situations: fat, iron, or hemorrhage. Here's an example of a young woman with dilated ventricles and biventricular dysfunction. She has thalassemia major and multiple blood transfusion and has multiple admissions for. The T1 map shows markedly reduced T1 value of 570 milliseconds. Note that the normal value on this particular scanner is 970 milliseconds. We just saw that the native T1 can be reduced in the presence of iron or fat. In this woman with multiple transfusions, there is likelihood of significant myocardial iron overload. T2 star mapping is a well-validated technique that is done in the cases of suspected iron overload. The T2 star values are markedly reduced, 7 milliseconds, confirming severe myocardial iron overload. With CMR, we are thinking beyond disease process. We are looking also at tissue processes. Is there infarction, inflammation, diffuse fibrosis, amyloid deposition, iron deposition, fat, Fabry's disease, etc. Let us now talk about hypertrophic cardiomyopathy. As we all know that HCM has many phenotypes beyond asymmetric septal hypertrophy. Thickening of the ventricular walls may present as sigmoid septal thickening, reverse curvature hypertrophy, neutral, midventricular, or apical variants. The high spatial and contrast resolution of cardiac MRI enables easy recognition of morphology and phenotype of HCM. High-risk features of HCM that can be identified on cardiac MRI include a wall thickness greater than 30 millimeters, LGE burden greater than 10 to 15%, which is associated with increased event rate, apical aneurysms. A common misconception that I see in my practice is overdiagnosis of hypertrophic cardiomyopathy based on septal hypertrophy phenotype. Common things being more common, sigmoid septal thickening of the elderly is much more common than a true genetic HCM. Remember that HCM is a result of genetic mutation in sarcomeric genes. Only 10% of sigmoid septum have a genetic mutation, while 80% of reverse curvature phenotype are associated with genotype mutations. Other conditions that can result in thick walls are shown in the chart here. Of note, it is important to note that measurement errors can result in erroneous diagnosis of HCM. In this example shown here, a patient was labeled in 2017 as HCM based on increased septal wall thickness. This patient had a repeat MRI 6 years later, which did not show the thickened septum. However, if you carefully see, we can see that the adjacent RV trabeculation was included in the measurement of the septal wall that resulted in the erroneous diagnosis. There are several conditions that can appear similar to HCM but are not due to sarcomeric mutations. These phenocopies may be a result of conditions such as amyloid, hypertensive cardiomyopathy, athlete's heart, or storage disorder. LGE patterns can be helpful in differentiating the various forms of heritable cardiomyopathies. Here's an example of Fabry's disease, which looks like HCM with massively thickened myocardium and papillary muscles on both echo and CMR, with a binary endocardial appearance of the LV walls on the echo and LGE in the infralateral walls. Another example of a rare X-linked glycogen storage disorder called Dannon's disease, which is from a LAMP2 mutation. A characteristic appearance is described in this condition where there's extensive LGE sparing the mid-septum. While diagnostic patterns on cardiac MRI may suggest the diagnosis, definitive diagnosis requires genetic testing. We're learning more about genetic mutations and patterns on LGE. Certain genetic mutations, such as desmoplakin, filamin C, lamin A, and phospholamban mutations, can present with a ring-like enhancement pattern on LGE. Integrating genetics with imaging features is key to diagnosis. While the pattern of LGE can help us with diagnosis, the presence, distribution, and extent of LGE in dilated cardiomyopathies is associated with adverse prognosis. The way we think about cardiomyopathies in 2024 has evolved substantially compared to the past. The 2023 ESC guidelines lay out an excellent framework on how we can incorporate advances in genetics and cardiac imaging into our diagnostic and management approaches of cardiomyopathy. Again, cardiac MRI plays a central role in defining the phenotypes of cardiomyopathies, guiding the next steps for management. Genetics are upending our previous assumptions in cardiomyopathies. We may have to unlearn a few things. As the great philosopher Rumi said, recognize that unlearning is the highest form of learning. Stay tuned for future. It is magnetic. Thank you for your time.